Good morning, ladies and gentlemen. I'm really appreciate to have a chance to have a talk in this big conference, cancer conference in Bangladesh. This is my first time in Bangladesh. So my presentation is about the management of cancer pain. So cancer pain is the most burdensome symptom. It's a top 5 cause that bring the patient to emergency department, and you can see how people suffering from pain. And pain control is also a humanitarian response that everyone should get this. For cancer pain, whatever you are, a curative treatment, you are in the anti-cancer treatment, or you're in the advanced stage terminal disease, everyone have a high prevalence of a cancer pain. Despite a patient who have already have a pain analgesia already, 40% of them also have uncontrolled pain. When we talk about cancer pain, most of healthcare providers think about, oh, this is caused of the tumor. We already focus on tumor, but more than that, they have like a cancer treatment, surgery, catheters, many things. Chemotherapy, radiation can cause inflammation, chest tightness, many things can cause pain for this kind of patients. And also comorbidities, they can have like osteoarthritis, many things. This is a prevalence of pain. The blue bar is pain. You can see the blue bar on the first of every disease. The first bar is blue, right? This is a pain. You can see every advanced disease also have high prevalence of pain. So we need to consider about each comorbidities, heart failure, COPD, CKD, dementia, HIV, and other disease. And other symptoms such as depression, anxiety, and difficult to breathe, chest tightness in the breast, breathlessness also can cause pain also. How many people in this room are palliative care providers? How many oncologists? Oh, okay, great. I think this is familiar to every palliative care providers that we have a concept of total pain. We need to do a whole holistic assessment, biopsychosocial and also spiritual. After this, some of my slides are from the WHO guideline cancer pain. So if the patient have a background pain, everyone, we need to prescribe regular around the clock medication every 4 hours, 6 hours, 12 hours, up to what medication you prescribe. And if the patient can swallow, we choose oral medication first and by the ladders, and need to interest in the individual and the detail of each patient's liver function, renal function, and comorbidities. I think everyone knows this 3-step analgesic ladders. And mostly when we look at this, on the second step is a weak, it suggests to use a weak opioid like a codeine and tramadol. And for the moderate to severe pain, on the third step, they just recommend for strong opioids such as morphine, fentanyl, methadone. And every guideline, NICE guideline, ESMO guideline, and every guideline also recommend the morphine is the first one that morphine is the first one that is recommend for the moderate to severe pain. And Dr. Marco Maltoni, he looked at this 3-step analgesic ladder and he said, is it possible that we just do only 2 steps? We can use strong opioid in the second step of the ladders. The result is strong opioid can reduce the number of days in the pain. That means a patient have a better pain control when they get a strong opioid. Okay, EAPC also recommend that the second step of the ladder we can use strong opioid such as morphine and oxycodone. It's very effective. So, but when we see the world map, we can see the well-developed palliative care country such as Australia, USA, and Canada. They have a lot of opioid consumption for palliative care patients. And when we look at Asian, such as Thailand and here Bangladesh, our country are collapsed. We use only less, so we use very less opioid than it should be. That means a lot of our patients may not get enough pain medications, pain relief. And for the cancer patient, a lot of them have a bone metastasis and at cause of pain. So every palliative physician can prescribe denosumab and bisphosphonate to prevent skeletal-related event. And if the patient have a bone metastasis and they have a bone pain, NSAID and paracetamol is very good to reduce an inflammation and reduce the bone pain. Radiotherapy is very effective for the patient who have like a more than 3 months survival. It's a good choice. But the patient when they have only two or less than 2 months, 1 month survival, single fraction or few fraction of high dose, maybe 400, 1500 centigrade is effective. And also bone surgery. So when the pain medication, I mean the oral medication and systemic medication is not work, another step is the fourth step, is a pain intervention by anesthesiologist. We can do like a celiac plexus block, brachial plexus block, intrathecal steroid, intrathecal analgesia. This is another choice in the intractable pain, uncontrolled pain, difficult pain. So it's nearly lunchtime. Do you need some exercise? So this is one of my case. He is a 20 years old male and diagnosis with advanced osteosarcoma on the left thigh with lung metastasis. The mass is very huge. He complained about very severe pain all the times. We start with oral medication, oral morphine. It's not work. We titrate morphine up and up until we get a morphine IV drip 5 milligram per ounce and gabapentin 600 milligrams a day. He also requests morphine 10 milligram for rescue 5 times a day. What should we do with this patient? Sorry? Bisphosphonate. Yes, yes, yes. And yes, please.
Thank you for your excellent presentation, and we are connecting with your presentation. If this pain is mixed type of pain, then he has got nociceptive pain and neuropathic pain. Then gabapentin we can increase dose. Morphine, if the patient is not drowsy and not having any toxic side effects of morphine, then we can go with morphine, increasing morphine dose. And we still we have paracetamol and NSAID for bone pain. And if with NSAID we can manage his left thigh bone pain, then we can add bisphosphonate, dexamethasone. We have all other denosumab. We have all others medicators for reducing bone pain.
Thank you. Excellent answer. Yes. As you mentioned, we also do that. Yes. So, in my practice, when we face like a difficult pain, difficult situation, one thing that we need to do is back to basic. We need to reassessment everything again. Did we treat the right pain? We try to increase a lot of opioid. Is it only nociceptive or it's just neuropathic that has a very high level of neuropathic? We need to check. Do patients have any side effect? How much gap that we can titrate opioid up? can we prescribe some adjuvant, as you mentioned? And this is sometimes we found patients have an acute on top chronic pain, their previous pain. That's why we need to recheck again when something wrong with our management, back to basic and recheck everything. Also intervention I mentioned already. So when we talk about when the patient get a high dose of opioid, and sometimes they get side effect, drowsy, myoclonus, but we cannot reach the target of pain control. We would think about opioid rotation, right? And it's because of a pain receptor. They have a lot of pain receptor. At least, as we know at now, 7 subtype of pain receptor, kappa and delta for nociceptive pain. When we do a rotation, the new receptor will get the new receptor. They never use it. It's very active. So when we do opioid rotation, it will work very well. Especially methadone. I want to highlight methadone because methadone, they have a target receptor for mu, kappa, and delta for nociceptive pain, and also NMDA and SNRI for neuropathic pain. It's like a broad opioid, broad painkiller. It mostly when we have like a situation for opioid tolerance, we would think about this methadone or ketamines. So ketamines, most of anesthesiologists use it in the operation room, but we can use it in the neuropathic pain and intractable pain. They have a lot of they have many and vary regimen and starting dose. It's up to regimen that you prefer, that you familiar with it. So this is my two last slide. This is a summary for the pain evaluation. We need to evaluate the severity of pain. If the patient have a mild pain, okay, we can just give it a paracetamol or NSAID. But they have a moderate to severe pain, we would think about morphine. We should prescribe more morphine to get an effective pain control and differentiate the type of pain and differentiate the patterns. If the patient have background pain, we need to prescribe around the clock, and don't forget to prescribe rescue medicine. When the patient have any symptom, what we look out is what is the cause. Is this correctable or uncorrectable? We need to find out and try to correct it. For the pain management, after we do a holistic assessment, we need to do a holistic management. Also give a pain medication, pharmaco, non-pharmaco, every type of pain, control other symptoms also, empiric symptom management, and try to get a specific symptom management. Look at the patient condition to adjust the dose. Do they have any condition that we should aware, liver, renal, or age? Look at the side effect, and we need to monitor severity and also trajectory of disease and other comorbids. Do they have another things happening with them? So as I'm a palliative care and I have a lot of colleagues in oncology, I always talk to them. Oh, we are on the same team. We have the same objective to maintain patients' function and quality of life. Don't be afraid when I look at your patients. We are the same team. Thank you.